Excellent. Thank you. Okay. Excellent talk, Mohsen. I had those really crazy cases also in the lung, and sometimes, the morphology still is much more helpful than the immunostains we do. So we're going to start with my talk. And I'm going to present something that I always feel I have problems with. And this is a very common scenario in head and neck cytology because the surgeons really want an answer on these things that pop up in the neck. And as the population is growing older, as you know, smoking even is going down, but there is different types of smoking that is happening in US. So people are still exposed to smoke. Plus, there are other factors that really are a reason for many lesions in the head and neck, especially the squamous lesions. So I'm going to talk about this topic that I always mess up myself diagnostically. I have a lot of challenges, which is the cystic lesions in the neck. And that gives me a lot of problems because the cytology material is very limited. And also we are so much operator dependent. If you're doing your own biopsies, it is great. Otherwise, it can be really challenging when these samples are coming from different. Okay, so I do not have any disclosures. I'm sorry I did not use that slide yesterday, which IAC requires us to use that slide. So I wish I did at this age group, but I don't. So we're going to start with this case, and this was my case, a real case. I was a 60-year-old showed up with a right neck mass, which he noticed during his shaving, and he said mass was going down, but then he noticed again, and his wife pointed out that this is a lateral kind of neck mass, which he was really feeling during his shaving. Not huge, but it was there. When I was called into the ENT clinic, we felt it, and it was looked like a tail parotid versus a lymph node. We did send him for ultrasound, and the ultrasound showed a cystic mass, and it favored it to be metastasis to a cervical lymph node. And they also always do a thyroid ultrasound because in the lateral neck, you always have to be something that pops up in the neck without any sore throat history or anything else. You have to be careful because this could be a metastasis from an occult thyroid carcinoma. They did do a pen endoscopy at that time and really did not notice any mucosal abnormalities, or there was no mass in the right tonsil. They felt a little bump in the right tonsil, but it was not ulcerated or anything. So they put it as a question mark, but they really wanted this to be biopsied by cytology. So this was the smear that I got, and this is the really a high power of an alcohol fixed light. And what you have is really a lot of kind of mostly blood in the background. There's not a lot of even inflammatory cells and some few cells that I took as much high power as possible for you guys. And you can see these are very highly kind of keratinized cells with a really large nuclei in there. So this was a little concerning. Then this was another cell that really pointed out, and as we know, that the squamous lesions really do not follow, especially the ones which are mature squamous epithelium look to them, or hyperkeratotic, the correct term. They really do not follow the rules that we learn about carcinomas. They may not show a high NC ratio. Actually, sometimes they have more cytoplasm, and the nucleus may be very pycnotic and round and dark. It's basically the nuclear kind of morphology is where we really mention, and the shape of the nucleus is much more countable in these cases. So these cells did look very atypical on this. Now, what was very important is that when you are dealing with a cystic lesion on site, which I always do, I always tell them to do as many passes as possible and basically put a lot of suction on the syringe. Usually when you're doing FNAs, you leave a vacuum in the syringe, and you really do not provide too much suction at that because you may get a lot of blood in those cases, which may dilute your specimen. But in these cases, I always get as much fluid as possible because I want to do that concentration technique, which can be tin prep or cytospin or whatever you do in your institution, I try to save that material for that, because on site, smearing a lot of, as you all know, you have a lot of experience, all of you sitting in the audience, that it does not lead to anything, and most of the cells kind of go shift to the edge of the slide. So these were the really important cells in these, and as you can see here, some of these cells have a very kind of large nuclei. There is a very round cell with a high nuclear to cytoplasmic ratio. Even there is no nuclear membrane abnormalities. You can see here really beautiful chromatin difference, which really has an abnormal U and heterochromatin here. What is also important is in the background, these cells, which look like a ghost of keratinized cells. And here you can see one of the cells which can be almost sold as this abnormal fiber cell, which we see in keratinizing squamous cell carcinomas or the squamous cell carcinoma mets, because it does not, the primary does not have to be keratinizing, because sometimes the metastasis is the one which shows keratinizing squamous and can be cystic, especially the HPV-related squamous cell carcinomas. So these, this was very important. And what I also want to point out this, which I have learned to really respect a lot, is this type of material, as you can see, what I call as clinging necrosis. So there's like a little debris that kind of sticks to the cell, and you can see it here also. So that is very important in these lesions, because as I said, in cytology, everything really matters. So this is another stuff here, and I want to really point out this clinging type necrosis, which is attached almost, if you look at it, the first thought is these are all degenerating cells, but these are tumor cells which are degenerating. These are not just degenerating cells, and you cannot just go, this is not enough degenerating specimen next case. So this really has the morphologic clues. Paired really abnormal keratinization or abnormally maturing cells. The round cells should not be so keratinized, and you can see here the nucleus really falling apart, but this abnormal maturation is very important for these lesions, because these cystic lesions are not going to give you a lot of cells. So for me, this was enough to really let them know that this looks like at least a squamous cell carcinoma, and that's how I diagnosed it. So they went in and they biopsied the tonsil, and as you can see, this is a squamous cell carcinoma in the tonsil, which is now called as HPV-related squamous cell carcinoma, and this was also P16 positive. There's a little bit of a controversy now that should we be doing P16 immunostain on the cytology specimens, and we're talking about cell block specimens. The CAP now, the College of American Pathologists, has really recommended that we should not be doing the P16 immunostain on the cell block, because there is sometimes it does not completely correlate to the surgical pathology specimens and how many cells we need, because in SearchPath you need 70% or higher number. What is that? And there are a lot of studies which even go, if you have 10 cells or even 2 cells positive, that correlates. So there's a lot of literature variability on this in cytology. I do sometimes P16 if they ask me, but I also submit it for molecular, which is the same test that we do for HPV testing for the pap smears, for the pap stain stuff, and then, for the GYN specimens, and that also works. So whatever works in your institution, but these are really specific. I don't know how, I apologize for being not so up on this knowledge. I don't know what, how many of these you see in Pakistan actually, or you guys really, but and in US we do see these a lot. Now I'm going to go into a second case, which was actually shared to me by one of our really astute faculty, who is a junior faculty, Dr. Jalali, and he had this case and he brought it to me, and he always brings me these cystic carcinoma cases, because he goes like, this is another cystic lesion, Zubair, so look at it and let me know what you think. And we always kind of go back and forth. So this is again a 40-year-old man who had a left lateral neck mass. He noted the mass himself and reports that it fluctuates in size. And he basically kind of sat on this mass, which is very common, the denial in that cases. Ultrasound was very concerning. It showed a mass which measured 4.6 by 3 centimeters. And CT said that this mass is anteromedial to the left internal cleidocledomastoid. So it's basically a tail of parotid, and it's also a little bit on the sternocleidomastoid, but really not sitting on the top of it. And they measured it by CT as 3 centimeters. So this was the cytology. So this is the diffquic state, and I'm showing you one of the high powers because to me, sometimes the low power, and I will show you a case when we go back to our unknown cases, which is actually, for me, that is much more fun. As you can see here, a little bit of a degenerated, like a ghost of cells. There's a lot of this debris in the background. Again, you see some really mature cells. So this kind of a very waxy look where the stain really does not take over. And some stuff, which is, again, here you can see there are really these empty areas, which is very typical of these lesions. But this is very different to what I showed you before on the cytology that I showed you. This is here has more of an inflammatory kind of look to it. Now, there are squamous cells in the background. And these squamous cells look like more mature squamous cells. They still have nuclei, but one still has to be careful because a well-differentiated squamous cell carcinoma MET or HPV-related METs can have these keratinized cells. Really not many abnormal cells, but if you look at these cells, they are mostly kind of degenerating cells and really have these really small, nondescript kind of nuclei. This is as much stuff as I can get for you from the slide. So I put all these in these boxes. And as you can see, some of these cells do have like this tadpole appearance, but they really do not have those nuclei that we come to associate with high-grade squamous lesions or squamous cell carcinomas. Some of the cells do have these tentacles, kind of pseudopods, which is, again has been described in cytology, kind of a little bit of a reparative look. So this was called as actually a cystic lesion. Squamous line does have some atypical cells, even though I and him thought that this may not. But you know, when we give opinions in a group, we're not telling anybody how to sign out a case. We're basically letting them know how we will handle it. So everybody does this individually. And it's a very respectful way of working in a group than saying, I know more than you or you know less than me. So that doesn't work actually for me. I think it's all about the opinion. So this is how it was called. Squamous cells with marked nuclear atypia and the background of necrosis and a squamous cell carcinoma cannot be excluded because the patient's age and you know this HPV's related cancers kind of always throwing a curveball. You have to be careful. So this was the diagnosis in this case. And it came out, this was a cystic mass. And as you can see here, really a huge cyst and a little bit of a multinoculation. There's a little bit of a debris. And as you can see around, there's a very faint lining in this, but there is really not much of a solid component to it. And this is actually the best lining that we can see. And you can see there's a good amount of lymphocytes in the background. There's fibroconnective tissue and very mature squamous epithelia. And if you look at this squamous epithelium, it has a really good layers of maturation to it. It's not haphazard. And this is what we saw on cytology also. So I think this is actually a good case of a branchial cleft cyst, which is inflamed. Not such a clear-cut case. And then most of the debris in the middle was what we see typically in these tumors. And actually, you can even see some of the bacteria here. And these are the cells that I can really correlate to what we saw, very repetitive looking cells. And I think the correlations really teach us so much. So, I mean, I think its correlation is not just for like, okay, I call this is this, but really diving deep and looking at where those cells are coming from, to me, is the way to learn this. But that, having said that, I will say the disclaimer is this is how it works for me. It may not work for all of us. But really, these are the cells which we see, those pseudopods, very repetitive look to the cells. So those cells, I think, are very typical of these lesions. But, you know, again, you're dealing with morphology, which is not 100% all the time, but this is what is helpful in these cases. So when we look at the cystic lesions in the head and neck, I think there has to be some kind of algorithmic approach to it. And to me, these are divided. If you go back to the basics as congenital, acquired, And the majority in the younger age groups are developmental cysts and are benign. And in children and adolescents and adults, they can be inflammatory or neoplastic. So this is like the basic breakdown for it. And this is how I mean, this list is large, huge. This is a very small version of the list that I actually basically have it on my phone. And I really kind of look at it. And for me, these are the ones that we are commonly going to see on the top here. Even some of them are not that common, but this is what we see in the everyday practice. And I think what also matters is the real estate. What I mean is where this cyst is located. And this is where you need radiology help, because not all the specimens we are on site. Sometimes they come in a cup, and then we have to go and ask the radiologist where they are listed. So this is really a kind of, I have divided them based upon the pediatric age group and the adult age group. And there are a couple, I gave you reference also. This is actually a very good article. And most of these are in the ENT literature, not in the pathology literature. So if we look at the location of these and we say what is in the midline, as you can see, they can be in the sublingual lesion, thyroglossal duct cyst, dermoid cyst, which is also in the midline, and thymic cyst. We really do not think of a thymic cyst most of the time, but in the children, the thymus is the cervical thymus, or the portion of the thymus in the neck, is very common. And the thymic inclusions in the thyroid and other areas in the neck are also common, and they can give rise to the cyst, and they can give rise to squamous cells plus lymphocytes. And then also remember, the patients with multinodular goiter or toxic nodular goiter can have these parasitic thyroid nodules which break off from the thyroid and sit in the neck, and they can become cystic. So it doesn't always have to be attached to the thyroid to be a thyroid follicular cyst. So these are the ones that, and then if you think about the lateral portions of it, they can be in the talar parotid or the branchial cleft cyst. Also remember, there are many lymph nodes in these regions. So I'm just going to go in and show you different slides. So these are the initial presentations. This is all in the clinical literature, but as we know, sometimes the symptoms and signs can vary. So these are the initial presentations of patients who have squamous cell carcinomas, which usually present with lymph node neck mets. And most of the time they are diagnosed like this. And as you can see, there's a whole list of these symptoms. So this is kind of my version of bringing this all back home. And I think I'm going to focus a little bit on the branchial cleft cyst. And as we know, there are 4 types, main types. The most common one is the second branchial cleft cyst. And it's very important to notice their location, the anatomic location. And this is where our embryology and anatomic, anatomy knowledge really helps us, because I think this is very, very important when you deal with the head and neck lesions to make sense of what we're looking at. So the first branchial cleft cyst, the situation and its relationship to the sternocleidomastoid muscle is very, very helpful. What happens is sometimes the thyroglossal duct cyst, which is supposed to be in the midline, when they get infected and filled, they can also move a little laterally in the neck and can mimic branchial cleft cyst. So one has to be really aware of these permutation of the exact locations that we see. So second branchial cleft cyst is the most common one, and that's why it can mimic lymph node mets, and these tend to be more anterior to the sternocleidomastoid muscle as compared to the first branchial cleft cyst, which is basically sitting on the muscle and at the angle of the jaw or close to the ear. And this is kind of a drawing that kind of tells you more easily that where these things are located and their relationship to the sternocleidomastoid muscle. As you can see, the third branchial cleft cyst, or the fistula, is much more down to the neck and actually can mimic supraclavicular lymph nodes. So I think this location, the real estate, is very, very important. The radiology, the best radiology for them is also a CT scan. I usually don't deal with CT scans until I'm dealing with more of a salivary gland tumors or squamous cell carcinomas. But when these cystic masses, which are easily approachable by ultrasound, I think the CT scan can really show where these are related, relationship to sternocleidomastoid muscle and the surrounding salivary gland. So I think that really helps. And also it kind of tells you whether this is attenuated on the contrast, how this is going to be on the CT scan. So most of the branchial cleft cysts really do not light up on the contrast. They have these really smooth borders as shown in this slide here. And their relationship, you can see it's really sitting right in there. Doesn't have any infiltrated pattern or no debris in it. So the CT really helps you more of the relationship with the surrounding organs, which sometimes the ultrasound cannot. Dr. Ahuja, who's, and I think he's in Hong Kong, actually. I think this is one of the best radiologists that I have come across with the head and neck, because he has published so much on the ultrasound. A very, very nice guy. And I also found out that he speaks Sindhi. So whenever I am from Hyderabad, Pakistan, so, I speak Sindhi. And so I met him at one of the conferences, and we just kind of hit it off. And we talked so much, and it was Sindhi talking and using all the medical terms. So it was a lot of fun. And he actually sent me his book. And it's a small monograph on the ultrasound of the neck. Anil Ahuja is his name, and actually he's in Hong Kong. So he gave me this picture from his book, sent it to me, and I said, I'm going to use this. And this is actually, he has published many articles also. So this is how the ultrasound shows these cysts. They are very anechoic. That means they are this dark black because they are filled with fluid. And you can see the ultrasound waves pass through them, and they do not reflect back. They always have this very brighter shadow at the bottom, which is because the sound waves go so fast and they hit the back muscles and stuff, and they come back, and it creates this acoustic enhancement, what she told me, this brighter shadow at the bottom, which is very typical of these fluid filled cysts. Now, the things do get complicated when they get infected, and then they become very solid. They have debris in them, and they can actually even mimic solid growths within these, which can happen in them, but most of the time it's debris and not really. And the other thing is also, because these cysts are so close to the lymph nodes, which are draining them, you can see these lymph nodes, little reactive lymph nodes surrounding them. And that's why sometimes they are mistaken as being a lymph node mat in a lymph node chain. So I think that this is really a best picture. And I really commend him for putting this together. So this is, again, my version of, which I think is a little hard to remember, but it's good to keep an idea of where all these things are located in the neck and which are the triangles and how these cysts relate to either their lymph node mats or what you're dealing with is a branchial cleft cyst. Now, when there is a lymph node involvement, this is very important also on ultrasound. And I don't want to give you a radiology lesson here, but I think it's good to use this for correlation. The normal lymph node tends to be more of an oval shape. And this kind of pattern, this echogenic pattern in it, is more of what is called as a fatty hilum. So when this fatty hilum is there, that means that lymph node is most likely benign. Because as you know, if the lymph node is taken by another process, the lymph node structure is going to change. So this is actually how the normal lymph node looks. They're more elliptical or oval in shape as compared to the lymph nodes which are involved by a metastatic process. They are filled with debris, so they develop these echogenic structures in them. And the most common thing is that they lose their fatty hilum in most cases, and they also become rounder in shape. Now, you can see when I showed you the pictures of a branchial cleft cyst versus this, there's not much of a difference. And that's why they get mistaken for each other. So I think it's very, very important to notice that's how these things can mimic each other. And I think, I'm sure you all know this, but I think it's important to kind of remind yourself. So from a typical branchial cleft cyst, you're going to get this white, yellow colored turbid fluid. You will get squamous cells, which will be atypical. And again, as we know, atypia is in the eyes of the beholder. What is atypical to you may not be atypical to me, or mine may not be, because this is what we're dealing with the grays on. But the lesson is that as soon as you see something that you think is atypical, do not be shy away not to call it, because you really do not want to miss that squamous cell carcinoma mat, which is from a occult primary, which most commonly happens to be in the tonsil. You do get cellular debris, you do get inflammatory cells. the question arises, and I always question myself when I see a 40-plus-year-old man and it's more common in males, when you see these cystic masses, the branchial cleft cyst diagnosis for me is a diagnosis of exclusion. I've excluded everything else before I say this is branchial cleft cyst, because sometimes the patients may not undergo surgery. So let's look at it. And as I said, this is really not easy. This is another case of a cystic mass, which was in this 45-year-old man. He has a history of smoking and also alcohol use, not abuse, but use. And as you can see, a lot of inflammatory cells in the background. I do want to notice, to point out to you, this kind of a waxy, empty spaces, which are actually these mature squamous cells, which are anucleated squamous cells, which is more common in these inflammatory conditions rather than in malignant. Not 100%, but there is a lot of overlapping. There's a lot of lymphocytes in the background, but on the high part, again, those cells with the kind of pseudopod looking cells, which have this kind of repetitive look, and those really high nuclei. This is still called as atypical, but this is the case that when it came out, and again, I just want to re-emphasize, there's those repetitive cells that you get. And when you're putting a needle in, the needle also goes to the path of the least resistance. What you're going to get in those needles is these cells which are in the middle of the cystic cavity. And as you can see, some of these taken without the context of the whole epithelium and the whole picture here, they can appear very atypical, because this cell in a cytology specimen will look really atypical. So there has been a lot of literature. And even we have published one of these cases really in the past. I mean, when you get to my age, you realize you published this like 20 years ago. But there is still a lot of literature coming out on this. So these are the ones which have been described. Some people have used P53 staining also on these. But to me, staining a cytology specimen, which has a lot of necrosis, a lot of debris and degenerating cell, it's kind of crazy, because you can get a lot of background staining and it may not be uninterpretable. But, the cell groups and the single cells, benign versus malignant versus anucleated cells and the nuclear ATPF. What I think really holds to me is that clinging necrosis that I showed you, so that background necrotic debris that is attached to the single cells, which look atypical to me, is the finding that I find to be more reproducible, even for me, than taking all the other ones. So the inflamed branchial cleft cyst can have these hyperkeratotic cells with this really beautiful pseudopod type of reparative appearance. You may or may not see neutrophils in the background, depending upon where you're catching this, but as compared to the squamous cell carcinoma mets, which are hyperkeratinized. So this is actually, again, I will emphasize that this debris, do not undervalue this debris, which is attached to the cell. So that's the clinging necrosis. Plus, they always have this small pearl formation with the cell within cell pattern. So that is, to me, is definitely for squamous cell carcinoma. So I think, again, everything matters. They are very difficult lesions. They can be diagnosed on cytology, but when in doubt, it's okay to call them atypical and say that this is, and immunostains may help or may not help. There are now reports. There are actually not reports, I will say, I will correct myself, case series in which people have done HPV DNA, and they have found the HPV DNA to be also seen in the benign lesions, which includes branchial cleft cysts as well as lymphoepithelial cysts. I don't know if Syed is in today or not, but he has actually one of the series of lymphoepithelial cysts, which were HPV DNA positive. I do not have much information on the RNA-ish or doing HPV, how that is going to be positive in those cases, but we have lined up some cases to do that, because I think that may be a way to go. But usually this is limited survey specimens, so I really do not muck around much with them. But to me, a good clear-cut case with those reparative cells and the radiology can be called as branchial cleft cysts, but when in doubt, it's okay to call them atypical. So now this is when we're talking about squamous lesions in the neck. And I'm going to deal with most of those squamous lesions, which really just gives rise to squamous cells. So you can see them a lot in other also. So this is actually was a left thyroid hypoechoic nodule, which was 5 centimeters. And this was lateral. This was not in the midline, because you can see dermoids in the thyroid, but they usually also happen to be in the midline, as well as sometimes the thyroglossal duct cyst can also have anucleated squamous cells because they can go under metaplasia. So these were new. I got these numerous anucleated squamous cells. There was no debris in the background, nothing. And again, there's a little bit of those reparative cells. So I basically said that these are numerous anucleated squamous cells. I don't see follicular cells. I don't think this is carcinoma, but basically a descriptive diagnosis in this case. So sometimes this can happen. Thyroid follicular cyst or thyroid cyst can have this amazing amount of squamous metaplasia. And this is not the atypical kind of metaplasia. This is just a plain metaplasia, and it can just mimic a simple squamous cyst. And when you do on SearchPath, when you see a case like this, when you do a TTF1 or Paxate on this, they really light up. So you can see here the follicular epithelium in the background, which is staining. And this is, again, lateral. This is not a midline, so this is not a thyroglossal duct cyst. And you can see again here, these cells are all staining, even the squamous cell nuclei staining with the TTF1. So this can happen in the setting of a multinodular goiter or a thyroid cyst. So be aware that sometimes these lateral neck cysts, so radiology will help you whether these are connected to the thyroid or not. Now, when you think of intra-thyroidal cystic lesions with the squamous cells, the differential is pretty big. This is few of them. One also remembers because the thyroid, the lateral lobes, the lateral analogs are coming from the branchial and they kind of move down here. So they really drag a lot of stuff with them, which can include salivary gland tissue, thymic tissue, and even branchial elements. This is where the C cells are kind of mixed in. So branchial cyst in the thyroid, remnant cysts are very common, lymphoepithelial cyst, and then the other benign one is the thyroid follicular cyst, which I showed you an example, and then the papillary thyroid carcinoma and the parathyroid. So think of other possibilities when you stick a needle in the thyroid and you get squamous cells. So this is something good to kind of remember by. Now, this is another version of the cystic masses in the neck. 35-year-old woman, no history, with a left lateral neck mass. And this is a kind of a Doppler image here, which I showed you. This is definitely a lymph node because you have this another version of a lymph node. This is round. So definitely this is abnormal. And on Doppler, you can see a little kind of solid component with a lot of vascularity to it. So this is definitely a typical finding that you see in a lateral neck where there is a metastasis. And in this age group, the most common site will be thyroid. And this patient actually on the ultrasound had no abnormalities in the thyroid gland. And that really throws in a lot of curveballs. So I was on site, and this was the first pass on the Diff-Quick or Romanovsky stem. And you can have this beautiful chicken wire appearance, which looks like colloid. But as we know, the ones who do really a lot of cytology, there are many things that can look like colloid. Like sometimes even the serum, the way the cells were dried up, you can get this kind of artifact, but this does look like colloid. And then you have these crushed cells on the other, so there's definitely lymphocytes in it. So you have lymphocytes and something which looks like colloid. Macrophages, so I'm showing you, this is the entire specimen looked like this. And I did not have any follicular cells. There were some degenerating cells, but mostly look very histiocytic. So no follicular cells in this. So this was my diagnosis. I said lymphocytes, and there are a few macrophages. In the background, in quotes, colloid type material, rule out metastatic papillary thyroid carcinoma. And we're going to discuss this. So what happens that this was taken out, and as you can see here, the beautiful cystic structure, and it really matches with what you saw in radiology. This solid kind of papillary growth here, lymphocytic cuff, and on higher power, you can see the nuclear features of papillary thyroid carcinoma and the colloid. So this was a metastatic papillary thyroid carcinoma. And it was TTF1 and thyroglobulin positive. On SearchPath, If you get a lymph node that looks like papillary thyroid carcinoma mets, please, if you have availability of a Paxate, TTF1, or thyroglobulin, do it, because there are few cases in which either it has been metastasis from the lung or from other sites which can mimic papillary thyroid carcinoma. Even there are tumors in the parotid or minor salivary glands that can have papillary cancer-like nuclei. So I think it's important, even if it looks like it, if you have availability for those stains, that's very important. Now, the thyroid was taken out after that lymph node dissection. And what we have is, this is a small papillary thyroid carcinoma, because in the new WHO classifications, we took away the term microcarcinomas. So, but I've just put it for you because that's what is still being used. We kind of discourage not to use the term microcarcinoma because it means sometimes these tumors are indolent, which some of them are, but some of them are also aggressive. So this is definitely a papillary thyroid carcinoma, which is very small, occult primary, and the first presentation being a lymph node met. So when you have a cystic mass with no history and there's no other radiology available, and you get the colloid-like material, so there's one way of handling it, like the way I signed up. Can we push it further? Can we really prove at this point so the patient may not undergo the two-step procedure? That means the surgical excision of that mass and then thyroidectomy. I mean, thyroidectomy is not a walk in the park, because even the most competent surgeons who do many, many thyroids, the rate of hypoparathyroidism is between 6 and 10%. And those are the rates from the American endocrine surgeons. So I think it's very important that when you're giving these diagnoses and the patients are going under these procedures, to really provide as much possible so they can have these procedures. They can have a diagnostic procedures or really a treatment procedures. So this is my version, is that if you have no on-site evaluation and if you're suspicious that this could be a met where you do not see those cells and you do not have to cell block, to me, the most that we find helpful is doing a thyroglobulin level assessment on that aspirate. So we take only 0.5 cc of that aspirate, mix it in the saline, and send it to our labs. And they have validated that test on the FNA material. And they look at the thyroglobulin, and the thyroglobulin in these aspirates, which are from the papillary thyroid carcinoma, is going to be very high. There's usually greater than 10 nanograms. This is what we use. American Thyroid Association says they're usually greater than 50. There are some cases which kind of escape this. Really poorly differentiated thyroid carcinoma mets, and even some of the tall cell subtypes may not have that much thyroglobulin. But I mean, this is something easily can be done if you do not have a cell block to do immunostains. And which usually you don't in these really cystic lesions. What you're getting is just these macrophages. So this is what I do. Basically, if I see a colloid-like material, even when the radiologist tells me there's nothing in the thyroid looks pristine, normal, I always send it. One caveat, remember we talked about when the patients have goiter, they can have these parasitic thyroid nodules in the neck, which can go under cystic change. If you do a thyroglobulin on those, you're still going to get a very high level. So, but those patients will have goiter. So you kind of have to think about those things. Now, as we're talking about the cyst in the neck, I do want to focus on this one topic. We talked about the cystic thyroid tumors, which can be parotid tumors, which are the secretory carcinomas, and Wharton, they can be cystic, or even benign mixed tumors can go under cystic change. We used to see these a lot initially, and then the numbers of these have much more dropped. So this is a patient who was 32-year-old. Look, see the age. And then he has bilateral parotid gland masses. I don't know how many of these you see in Pakistan, but I do get hit by these sometimes, and I always say they come in waves. And as you can see here, again, really this kind of material which has this kind of clear serous type quality. There are a lot of macrophages in the background and some lymphocytes. And there are cells which are a little rounder, but not really so abnormal looking. And if you really take into account without the cells, the Whartons come to mind because these can be bilateral and they can have this kind of a grungy material in the background. But what you notice is also that these anucleated squamous type cells in the background, which is really not so much of a feature in Wharton tumor unless it has been biopsied before. Having said that, that history is very, very important because the lesions that have been biopsied before, either in the thyroid or in the neck or in the salivary gland, can develop a squamous metaplasia. So that can be taken into account. So history is, I think, is one of the biggest weapons we have to really come up to these correct diagnoses. And I was able to get a cell block. And as you can see, this is a good case of a lymphoepithelial cyst, which can happen. And this patient was also HIV positive. So this, we used to see them a lot, but now the numbers have gone down, but here and there you will see them. So also think of lymphoepithelial cysts, and they do not have to be related due to HIV because, you can see them in the thyroid and you can see them in the other areas in the head and neck. So think of lymphoepithelial cyst. Also keep in mind when you're seeing the lymphocytes and you're seeing these squamous cells. So this is one of the lesions which is not very common now, but always, having that thought in the head. And sometimes you actually see them in children also where they can be developmental. So areas where, especially with the branchial elements. So I think this is very important. So when you are approaching a cystic lesion, I think as applies to any cytology, every cytology specimen, it's very important to think of these lesions and everything. So when we take the background, which is kind of mucoid, and we talked about mucus type backgrounds yesterday. Again, not 100%, but when you think that's the way the smearing and the stringiness of it is mucoid, you have to think about. So I always, it was late Dr. Rosai told me this one thing, how to handle anything in pathology. He said, if your differential is malignant first and the benign at the last, it's very hard for you to go to all the way to the benign diagnosis. Start thinking about things from the benign and then go up. So I always have these things in mind. So when you think of something mucoid with histiocytes and lymphocytes, we talk about mucus retention cysts or ranula that we talked yesterday, then the salivary gland lesions. And if you see the atypical cells, you could think of malignancy, which can be metastatic because there are some colloid carcinomas, like mucus carcinomas, which can metastasize, or they can even in the head and neck rarely. If you have the watery and proteinaceous fluid, which my talk now kind of focused on mostly, and if you have lymphocytic infiltrate and very few epithelial cells, which can be mature squamous cells, then you have to think about lymphoepithelial cysts or thyroglossal duct cyst. But again, real estate matters. Is it a lateral in the neck, where it is located in relationship to the sternocleidomastoid muscle? And if you're biopsying them manually, you can really feel the sternocleidomastoid because it's the most prominent muscle in the neck. So you can actually see the location and can judge it even by manual aspiration. Lymphocytes and oncocytes, think of the Wharton tumor, which is very common. And then atypical keratinized cells, squamous cell carcinomas definitely comes on the top, but metaplasia in a benign tumor, and as I pointed out, history of prior FNA is very, very important. Then keratinized cells, you have squamous cell carcinoma and the branchial cleft cyst. So I think the benign versus metastatic or malignant squamous cyst, I think it's a very difficult diagnosis on cytology. And even I have seen them, I have actually struggled with some of these even on SearchPath. So everything matters again, the inflammation, the necrotic debris, the cellularity, abnormal keratinization, which I use like the term dyskeratosis, which was an older term used inside, where there is an abnormal maturation. So the nucleus does not keep up with the keratinization that is going in the cytoplasm. So that abnormal keratinization is really, really important because that is more common in malignant lesions. And then definitely nuclear atypia. If you have a cystic mass that you are suspicious for thyroid cancer, you can recommend ultrasound of the thyroid and aspiration of any suspicious nodules that see, because it doesn't have to be a cystic tumors to metastasize as cystic. As you all know, papillary cancer mets can be saw from a solid, even the follicular variant can be a cystic mass. TTF1 and thyroglobulin, if you have enough cells. I will not advise this to do on a cytospin or a thin prep slide because the background proteins, thyroglobulin antibody is a very muddy antibody and it stains a lot of stuff in the background. Unlike TTF1, it's a nuclear stain, but then those cytologic preparation has to handle that processing of a nuclear staining. So cell block is very good. But for me, if you can set this up in your lab, is doing a thyroglobulin assessment of the FNA specimen. So that is the end of this talk for me, and I can take questions if you have any, and then we can move further to a next talk.